Minnesota. That's where he got his PhD. So, Robbie, I just want to enthusiastically welcome you to the group. It's a really fun and honest and straightforward group, and Robbie is very much the same. He is a straight shooter, so if you have questions, definitely ask them, and I'm excited for your presentation today, Robbie.
Well, thank you, Amber. I am assuming people can hear me, otherwise I'm talking to myself. I'll have to apologize beforehand. I may end up having a coughing fit in the middle because I have what's going around Pullman now. But I'm trying to do pretty well, and I think I'll be fine going through here. Please do ask questions as I go along. I tend to move fast, and if I'm going too fast especially, let me know. And if I go beyond where you ask a question, just tell me and I'll go back, because that I do that to people all the time. I want to process something, and then I'll say, hold it, I have a question from 3 slides ago. Can you go back? You won't upset me if you do that to me, because I do that to people all the time. So most of you, I assume, had met Sean Murphy, who preceded me as the economist on these projects. Sean was actually my student a little while ago, and when he went up to the health policy program up in Spokane, I was really happy to have him around. I'm very pleased for him for his new position in Cornell, but wish he was still at WSU. So with that, let me start my brief introduction to the economic analysis of intervention programs. Somebody is making noise, and if I could ask you to mute your mic, I'd appreciate it. Thank you.
Okay, this is Agnes. I just printed out the format for what Bruce has sent, so I'm going to go next door so it'll be quieter. I apologize.
That's okay. I just wanted to make sure it wasn't my computer. Okay,
no,
for those of you following along on your own, all the slides are numbered, and I'm going to tell you when I move to the next slide. So I'm moving the slide. I hope I'm moving the slide too. My computer's not responding.
That's okay. I think your format here is real good. So
okay.
It'll be briefer and save on time. Thank you.
Okay. So I have I'm on slide 2 now, and this is just a note to let you know where this presentation is derived from a CDC webcast. It's quite an extensive webcast of economic evaluation, goes way deeper and is much longer than what I'm sharing here. They have both slides. They also have videos that you can follow. And if you want to kind of teach yourself some more about economic evaluation, this is really a good place to go. So you might note that website as you go along if you want to explore this some more. So, what is economic evaluation? Well, to start, let me say that a lot of people think about economic evaluation as what economists say is accounting, because a lot of times people just want to add up the very obvious and measurable costs and benefits of an intervention, and then say that that's doing what an economic evaluation is. Economics goes way beyond the direct costs and measurable things. And what we try to do in economics is really understand the total value of something, including those things that are measurable and those things that are not measurable. I'm going to paraphrase Einstein at this point. Einstein said something like, everything that important is not measurable, and everything that's measurable is not important. Well, economists spend a lot of time trying to think about those things that are not measurable and come up with some measure for them anyway. And we're going to talk about one of those at the end of this presentation. So, what an economic evaluation does is compares the costs and benefits of an intervention, whatever you're studying. We're having to study some medical interventions. And it demonstrates to decision makers really whether the intervention is worth it. So if you have a measure of the benefits and you measure the costs, if the benefits outweigh the cost, it seems like it would be a good thing. And if the costs outweigh the benefits, maybe you could use your resources somewhere else. When policymakers have these things, they can use it to help prioritize the use of resources. It can help decision making and help set health policy. But overall, the goal is to identify, measure, evaluate, and compare the costs and results of programs and policies. When we do an economic analysis, we have, economists tend to think of things as inputs and outputs. And so the inputs to economic analysis are two parts. One is the economic impact analysis. And by that we mean we're really trying to see, if we do the intervention, what is the impact going to have on everything we can measure? And if we can't measure something, can we qualitatively say something about how the impact it will have? And then the programmatic costs analysis, which means we're trying to identify all those costs, the direct costs of the intervention, and the indirect costs. The indirect costs I'll talk about a little bit later, are things that are not necessarily falling on the people putting the program together, but often can be falling on those who participate in the program, or it can fall on others outside, which we call externalities. We really don't have very much externality here, but we have some. They're not really much of our issue in our analysis. So the two types of economic analysis that are usually used for interventions of the sort we're working with in this research are benefit cost analysis and cost effectiveness analysis. Sometimes people add a third called cost utility analysis, but that's really just a specific type of cost effectiveness analysis. So I don't separate it out, especially since we're going to do that, and I'll talk about it in a specific way. Excuse me. Okay, so the inputs, the first thing we want to talk about in the inputs are the economic impact analysis. And in this particular type of analysis, when we're talking about healthcare, the first thing we need to do is estimate the total cost, which includes medical and non-medical, of a disease or a condition. So in the programs that we're dealing with that deal with blood pressure, we'd really be looking at the costs of hypertension, for example. Medical costs include the direct and indirect costs of care and the treatment. So if we look at hypertension, we're going to look at the cost of treating hypertension, the expected bad outcomes that come with hypertension, things like that. Non-medical costs are productivity losses from not being able to work, extra transportation costs, all those sort of things that people often don't think about when they think of the cost of a direct intervention. We're going to try to come up with some measure of in this program, because that's what the true economic impact would be. And generally, reported as an annual total cost per patient or average patient lifetime costs. And we'll probably look at things different ways as we collect the data to try to analyze both the more immediate gains or losses from the intervention and the long-term gains and losses from the intervention. So once we have an economic impact analysis of a disease or condition, we can measure the potential benefits of prevention or avoidance. So if we know the cost of hypertension, we have a good estimate of the cost of hypertension over a person's lifetime, and then we find out an intervention can lower the incidence of hypertension. We can then estimate how much the intervention is saving in healthcare costs over the lifetime of an individual. Excuse me. Programmatic cost analysis estimates the total program costs and who incurs those costs. So we have both what we call financial and economic costs. Financial costs are those that show up in a budget sheet. That's what accountants do. Accountants are really good at identifying those financial costs you can put on a budget sheet. Economic costs include a lot of different things: in-kind services, cost to patients of obtaining the intervention, and other indirect costs to patients and providers. And I'm going to use a non-hypertension example here. A lot of times when we have some sort of need for home care, a lot of the home care is provided by family members. This cost takes the family members from at least 2 productive activities. Actually 3, I'll say. One would be work activities, potentially taking them away from employment outside the home. Another is other, what we call home production. So if you're taking care of a family member, you might be doing less cooking, less cleaning, less other things that make a home livable. And the third is enjoyment. If you're devoting your time somewhere, there's only 24 hours a day, it has to come out of other things. And if you still work outside the home and you're still doing the home production, then you're going to have less enjoyment. And so the economic cost would include the loss that an individual suffers from all those things, as well as the direct costs of the care of the individual at home. So we're trying to identify the cost of providing an intervention widely with a very broad definition that includes what economists tend to call opportunity costs. Because if you spend your time or money in one activity, that means you're not spending it on another activity, and that's the opportunity lost. So as I mentioned, the 2 types of economic analysis most often used in interventions are benefit cost analysis, which looks at, converts the program cost and benefits to dollars, compares whether the benefits or the costs are larger in dollar cents, and then helps identify programs that have a positive payoff overall. Theoretically, with unlimited resources, all programs for which benefits exceed costs should be pursued. I'm going to pursue a little bit more about benefit cost analysis, cost-effective analysis in a minute. Cost-effective, going back to benefit cost analysis for a minute, as the last bullet says, oh, by the way, I'm sorry, I've been moving along and I forgot to tell you, I'm on slide 7 already. Theoretically, with unlimited resources, all programs for which benefits exceed costs should be pursued. And that means that if we have a positive benefit, then you're going to want to do it because we've measured everything in dollars or whatever currency we're denominating things in. And so we get a return, a positive return by investing the money in the intervention. Resources aren't infinite, and so in that sense, benefit cost analysis is limited because we have to make choice. And that's where cost effectiveness analysis comes in. The program costs, again, are in dollars, and you can actually do cost effectiveness analysis with benefits measured in dollars as well. But usually we try to measure the benefits in some sort of natural unit, such as life years saved or blood pressure improvement. And I'm actually hoping to use both of those in our economic analysis as clinical measures of the intervention, clinical measures of the outcome of the intervention. The value of doing it this way is that cost effectiveness of different interventions can be compared and ranked according to gain. So we have several different interventions looking at blood pressure, for example, and we might find that they have differential gains in the incidence of hypertension among the populations. Doing the cost-effective analysis would let us say which of the interventions is more effective in preventing hypertension. Okay, and we do this in measures of dollars spent. Okay, moving to slide 8. A little bit more about benefit cost analysis. So once you've measured everything in monetary terms, so you have all the direct costs of the intervention, the time and equipment and supplies needed to do blood pressure measurement, the time cost of the individuals participating in the program, both as caregivers and as care receivers, the lost wages that the person who's coming to get their blood pressure measured might have, the transportation costs, all those things go into time. We have the costs. The benefits, as I mentioned, would be measured in terms of the dollar value of life years saved. Now, you might say, how can you measure life? Well, the value of life, well, economists measure the value of life all the time. We have a lot of different ways to do that. Some are better than others, but they basically are viewed by a societal perspective of how much is society willing to spend to avoid another death, or also to avoid some sort of morbidity. And so we also know, for example, the cost of hypertension. And if we can lower the incidence of hypertension, we can estimate the dollar savings in medical care that we could use elsewhere for not having so many people with hypertension. So these can include health and non-health benefits. We translate them to dollars, and we have costs and benefits. The nice thing about this is we don't have to have the costs and benefits occur at the same time. By using tools like discounting, we can bring everything to present value and compare lifetime costs, lifetime benefits, and come up with an overall measure of the value, the costs and the benefits of the intervention. And we usually measure in two ways. One is the benefit-cost ratio, B, the benefits divided by C. For every dollar spent on X, you will save Y dollars. This you implement it if the benefit-cost ratio is greater than 1. When choosing among programs this way, you tend to choose the benefit-cost ratio with the highest ratio. The other thing is called the net benefit, which is just the benefits minus the costs. And you implement it if the net benefit is positive. As I noted before, neither of these measures gives you a clear understanding if you have limited resources what you should do, nor does it necessarily show you really the best spending of your dollars, because if we have something that's very cheap with a low benefit cost ratio above 1 but still low compared to something else, so we can do it more widely, the overall benefits should be greater. So you always have to just start with these measures rather than finish with them. I'm going to do a little bit more about cost effectiveness analysis because I think it's less well known. This estimates the outcomes of interventions in natural units. In hypertension cases prevented, points on a blood pressure improvement or lives saved are levels that are natural units that would occur in the type of interventions that we're talking about mostly here. And you compare results with other interventions affecting the same outcome. So if we have more than one intervention that affects blood pressure, we can use points on blood pressure improved as a measure. We could also use the others. Certainly hypertension would be a case. But the place where cost-effective analysis using natural units comes into play is when we want to compare something like a hypertension intervention to a cancer intervention. Now we can look at lives saved and compare across different types of interventions that do not have other natural units to compare and compare the different interventions. Okay, moving to slide 10. 1 second, please. Okay. Sorry. The summary measure is the ratio of a net program cost divided by net program effects. It should be into net program effects. The effect standardized across most medical interventions is what's called a quality adjusted life year. And I'm going to talk about more on this later. And this is where we have been able to use economic impact analysis to be able to compare very different programs as different as medical interventions to building roads, to understand spending our social money on different uses. So, two or more programs affecting the same health outcome be compared in terms of incremental, not the cost of one program to another. But if we have things that are not affecting the same outcome, we can still compare them using quality adjusted life years. I'm going to talk about how we measure quality just life years in a little bit. We have a continuum, not a decision rule. So generally, we find that if you find through a lot of budgeting, I guess this is really from the CDC. If we have a low ratio, where it costs $30,000 or less to improve qualities, you have a good value. High ratios of $300,000 or more per quality are seldom a good value, and there's a continuum in between that's difficult to assess. There's different standards that the CDC uses for prevention versus treatment and clinical versus population-based interventions. Okay, so how do we assess the dollar value of benefits from benefit cost analysis? They can be direct, indirect, or intangible. I'm on slide 11, by the way. Sorry, I keep forgetting to say that. Direct benefits are the medical expenditures saved for other purposes. So again, I keep talking about if we reduce hypertension, we can have an expectation of fewer medical expenditures on hypertension and its side effects in the future. This is often difficult. There's a very famous economic study which made a lot of news for a while until it was looked at more carefully and debunked, that showed that when we get people to stop smoking, we increase healthcare costs because people live longer. Turns out, though, that when we get people to if you look at this carefully, if you get people to stop smoking, we do have a net benefit, but it's not as direct as we would have if we only measured the cost of the direct cost of smoking. Because people live longer, they tend to have other illnesses later in life, and so we have less of the gain than we want. So when we look at medical expenditure saved, we also have to take into account that we'll have additional medical expenditures someplace in the future. Indirect benefits include things like potential increase in earnings, productivity gains, intangible benefits like psychological benefits of health and satisfaction with life. And you might think we can't measure those things, but actually, especially satisfaction with life, this is a big area of study for economists, and there's a large literature talking about how to translate satisfaction with life into dollar benefits. There are different ways of assessing benefits. I'm going to talk specifically about what we're going to do with the qualities. So, just kind of summing up where we are now on slide 12. Our economic analysis compares the cost of blood pressure control interventions to downstream savings resulting from improved health relative to usual care. That's really looking at the direct benefits. We measure the cost as the incremental cost of the blood pressure intervention relative to the usual care, and sometimes that could be a savings. We measure it as a cost, but sometimes an intervention can actually be cheaper than the usual care, and can have either the same outcome, a better outcome, or a worse outcome. But we can still compare whether it's worthwhile in a benefit cost analysis that way. We measure benefits relative to the usual care in three ways: downstream cost savings and future health care costs from health improvement, clinical gains, which can be translated to additional life years, and the quality adjusted life years. Okay, so how are we going to measure programmatic costs? We're going to use something that's going to be adapted from what's called the DAT cap. And we're going to identify these from the providers of the intervention. Questions will be adapted from the DAT cap, which is a standardized set of questions which was put together for use in treating alcohol and drug programs. We're not doing alcohol and drug programs. We're going to have very different types of issues we have to deal with, but it will help us identify the specific costs, including medical supply, capital, and personnel needed for our interventions. So I want to emphasize we are not using the DAT cap, just going to provide a guide to the type of things we need to collect to make sure that we want to do that. that we're getting all the direct costs. The reason I want to use the DAT-CAP as the guide is because it's been well vetted, it's been approved by the NIH, the CDC for intervention programs in drug and alcohol, and it goes far beyond drug and alcohol interventions in trying to understand the direct costs of an intervention. And so for that purpose, I'm going to use it as, again, as a guide, not as the exact measure.
Hi, Robbie.
Yeah, go ahead.
This is Kaimi. I just had a quick question about this slide. So when you talk about providers, is that referring to we who are providing the interventions, or what providers?
We're talking about healthcare providers who the person would usually frequent if they're going to be involved, if this is going to change that. We're also mostly talking about the cost of the intervention itself. So, so we have an intervention of self-monitoring of blood pressure, right? Mm-hmm. But that has to be reported to the caregivers. And so what we're going to try to do is, and I'll get into the indirect measures, that would be the cost of the person of taking their own blood pressure measurements. But once it's reported to the caregivers are going to have to incorporate that into the records and care plan for the individuals over time, right? And so with the DAT-CAP, we're going to try to collect that information as well.
Okay, so my study is not going to be in a clinic setting. This is a community-based project.
Is this the
ENACTS?
I'm sorry, I'm not up on all the acronyms. Is this the groceries intervention?
Yes.
Okay, which I think is so absolutely cool. I can't tell you how excited I am about that one. It's just like the coolest idea. Okay, so with whatever, for that program, we're going to have to go in and we're going to have to talk to the grocery providers about how the intervention, because as I understand it, part of it's going to be trying to get them to, for example, put the healthier foods more obvious to people coming in, right?
Okay, so that's the Cheers project. The other one in Chickasaw. This one is with Native Hawaiians and Pacific Islanders.
Okay.
In Western Washington. So we are providing groceries, but
okay. So now, this is the box one, right?
No, no, that's Cheers also.
That's Cheers. Okay. I'm so far behind on all these.
That's okay. That's okay.
I have no idea how hard it is to come in to such extensive research in the middle.
I'm sure. So I think Cheers and my project are more community-based and not necessarily within clinics.
I understand that, but the communities are going to incur costs to do the intervention. Mm-hmm. There's going to be some community leader or some community organization that's going to be in charge of helping people understand what they need to do.
Right.
That's the information. That's the direct programmatic costs that we're going to try to collect.
Great.
So as we get on all this, boy, I'm starting to realize I have to give up the rest of my life because this is there's so much I have to learn. Okay, is that okay now? Okay. So those are all the direct costs, and then in addition, through the non-study resources form, which is going to be filled out by the participants, the subjects of the intervention, will help identify non-economic costs specific to program participants. So I shouldn't say non-economic costs. Some of them are economic costs like transportation and travel, but also non-economic costs like this is taking me so much of my time. And they might think it's an insignificant amount of time. It takes me 20 minutes to measure my blood pressure, and they say that's nothing, or it's not a big intervention. But when you add that over all the people we would like to be seeing doing that, it's going to have a big impact on time available for other things. Okay, moving on to slide 12. I'm sorry, slide 14. I can't even read my number. Our downstream cost savings. Primarily, we'll be using established measures of the cost of hypertension as treatment. We're not going to be having, as far as I understand from what I've read, we're not going to be having extensive follow-up of program participants to see how the results we've measured in a relatively short term translate into long-term gains in treatment costs. But we will have, for example, hopefully, lowered incidence of hypertension. And if we have a value on the lowered incidence of hypertension, we can then use established measures on the cost of hypertension as treatment to see what the gain would be globally. Additionally, we're going to adjust the measures culled from literature with response to program participants to what we gather from the non-study resources form on healthcare use, ancillary costs, and employment experience. So I guess this is a good place to segue into some of what I didn't think was I didn't think was a big problem, because I could understand it, about some of the questions that were considered inappropriate for the study, things about alcohol and drug use, for example. Part of the again, this is something inherited from previous studies, and what you're looking for in questions like that are ancillary costs of an individual that sometimes either exacerbate or mitigate normal hypertension, in this example, hypertension treatment costs. And so rather than asking them directly as we did, what we tried to do in changing the questionnaires was to make it open so that the individual can offer what they are comfortable offering without asking in any way that would be culturally inappropriate or insulting. So that's what we tried to do, Clem and I tried to do when we altered those forms. The other thing that we're going to do is clinical monitoring and outcomes gathered in the standardized core instrument. That will provide us a lot of the information and adjusting these measures as well. And this is useful for both the benefit cost analysis and the cost effectiveness analysis. Moving to slide 15. So our clinical gains, again, this is getting a little redundant, but sorry, it was kind of hard for me to organize all this. We're going to have blood pressure improvement, expected hypertension cases, and those should translate into changes in life expectancy. The first two can be analyzed directly with cost-effective analysis. Changes in life expectancy can be analyzed directly with cost-effective analysis, and by translating the lifetime income differences also with benefit cost analysis. This is another place where the non-study resources form comes into play, because we're trying to gain information about individuals' earnings potentials. And we'll be able to do that specifically for the study group itself. And this is important because we have a very special studies group. And we don't necessarily want to use the values that we would get from a general survey on wages. We don't use the average wage in the United States for this particular group, because it would undermine the quality and the validity of our analysis, because it's not pertinent to our group. And so we're going to try to use the non-study resources to gain more exact information to do a more pertinent analysis of things like income gains. Okay, now the gold standard in studies of this sort for doing cost-effective analysis is something called quality-adjusted life years. This is a standard outcome measure. QALYs incorporates both duration and health-related quality of life, and it's a recommended primary effectiveness outcome measure for economic evaluation studies. The truth is, and I'll get to this a little bit later, and if I don't, please somebody make sure I go get to it, is it has some problems with our study group as well. I'm on slide 16, by the way. Again, sorry. The value of QALYs is that it captures a wider range of consequences and clinical effectiveness, allows us to compare across diseases and interventions, as I mentioned, and allows for a broader economic interpretation. When people ask me what economists study, or when people think what economists study, most people think economists study dollars. You know, they think we talk about income and dollar measures. I have a completely different view of that. And when I go in and I teach introductory economics, I tell what people study is what makes people happy. We have this term we call utility, which is kind of our jargon term for happiness, and it's the basis for all economic analysis. And so we're studying what makes people happy, and what we do with qualities is we adjust how long people are going to live by how happy they're going to be as they live. And so you can have a short happy life, you can have a long unhappy life, or if the world is really good, you'll have a long happy life. And qualities are an attempt to get to that, how long is your life and how happy it is, and give us ways to trade it off. And that's the kind of the broader economic interpretation I'm talking about. Generally accepted cost-effectiveness thresholds for defining values have been established for qualities, which is not the case for clinical measures. Hence, in a lot of ways, with the NIH and the CDC especially, quality is the key measure for our analysis. Okay. So, you know, we've been talking among the research group with the methods core about different things that, different instruments and how we're going to ask some questions. The change in quality is estimated using this form called the EQ5D. And one thing I have been adamant about throughout my so far short participation has been that we have to administer the EQ5D as is with absolutely no changes. And that's because it's a standardized measure of health status developed by what's called the Euroqual group in order to provide a simple generic measure of health for clinical and economic appraisal. Okay? Now, when we say it's a standardized measure, it's been tested with, I think we're up to many hundreds of thousands of individuals in a lot of different cultures. And so with this measure, they've been able to come up with these simple questions, and I'll go through some examples in a little bit, ways to translate that into where somebody would fall on their view of happiness and how long they want to live with all this with this instrument. And because it's so standardized, that's why I keep insisting it has to be administered as is. What it does is for each individual, it provides a simple descriptive profile and a single index value, which includes health status, how the person views their life, how easy it is, how happy it is, that can be used in the economic evaluation of clinical interventions. Once we get this simple single index that describes the individual, we can put it into this enormous database of all these other people who've been measured in the past and say, here's where you looked before the intervention, here's how you said your life was, now we see how you've changed after the intervention, and we can adjust the expected qualities that you've gotten from the intervention. It's designed easily for self-completion by program participants, and it's very simple form, takes only a few minutes to complete. So here are some sample questions. And the idea is to ask it before the person has the intervention and then afterwards. So mobility, I have no problems in walking about, up to down to I am unable to walk. Now, are our interventions likely to have much of an effect here? Well, you might say no, especially with some of the monitoring ones, but certainly the diet interventions could have a big impact as people's whole health gets better. Usual activities, I have no problems with my usual activities. I am unable to do my usual activities in different gradations in between. And what we have found with using these so often and so widespread is that that people come to a fairly good understanding of it. Now, the truth is that in most, this is called a Likert scale, in most Likert scales, people either gravitate to the ends or the middle. So there's an EQ5D that actually has, this is called the EQD5L because it has 5 choices. There's an EQD3L which has only 3 choices, but most analyses have shown that the 5 choice is better. That we get a significant number of people who understand slight versus moderate versus severe. And if you give too few options, people really are confused as where they go. So we have asked questions about pain and discomfort, anxiety and depression. The truth is that in something like a hypertension intervention, if you look at this isn't all the questions, but we're probably not going to have much effect on mobility or usual activities. When we get to slide 19, probably not a change in pain and discomfort, but if people see their hypertension going down or they're getting a lower hypertension with less drug intervention, we might see a big increase or a big improvement, I should say, in their anxiety depression measures. So we start thinking about where we might see these measures, not that we're just trying to think of whether it's an appropriate form. Now moving to slide 20, this is kind of like the overall question. And this is really an important one for measuring the quality. So this is the ones we ask. We would like to know how good or bad your health is today. And the scale's numbered 0 to 100, with 100 being the best health you can imagine, and 0 meaning the worst. And we just ask them to put an X somewhere on the health is today, and then write the number in the middle. This is really a key in where the people show up. The other index values matter as well. Not trying to minimize them, but this is where we might see big improvements. Somebody who comes in with into one of our interventions with severe hypertension but no other problems might be so worried about that they're going to give themselves, pick a number, 40, right? And then if they see a big improvement in their hypertension measures and their blood pressure, they might come up and really significantly change the way they feel and how about their overall health. So this gives us a good view of how the person thinks about their health overall. Moving to slide 21. Okay, so now we have how to interpret the EQ5D. And so we have the health state, and we end up with these 5 dimensions, and there are not a lot of questions about each of them, okay? And so we have one dimension is anxiety and depression. Sometimes, if you look at it, you'll say there's only one question on it. Anxiety and depression, mobility, self-care, usual activities, and pain and discomfort. And they've responded to each of these questions on that scale of 1 to 5. Level 1 indicating no problems, level 5 indicating extreme problems with different gradients in between. So by combining this on each answer to each 5 dimension, we get a unique health state for each individual. So going to slide 22, we have, believe it or not, with 5 categories, we have 3,125 possible health states defined in this way. Well, excuse me 1 minute. Sorry about that. So each state is referred to in terms of the 5-digit code. For example, 111111 indicates no problems in any of the 5 dimensions. A 1, 2, 3, 4, 5 indicates no problems with mobility, slight problems with washing and dressing, moderate problems with usual activities, severe pain or discomfort, and extreme anxiety or depression. Now, we can also correlate these with the response to the question that was on slide 20. And so from those 5 responses, we can correlate it to how people think about their overall health. And we have now a nice distribution of both how people think about their overall health and the 3,125 possible health states and all the responses on this. Now, if you look at all the past studies done with the EQ5D5L, it can be converted into a single index of the general population. We have this distribution of the general population. This is where I have a slight, well, it's not even a slight. This is where we're going to have to be very clear about our study population. And while we are looking at the measure of quality improvement before and after the intervention, we have to hedge a little bit because Native American populations are not a large number in this general population. And as far as I can tell so far, I've not been able to get the information. They do not have a subsample analysis based just on Native American populations. So we're going to be comparing the gain in qualities to perhaps not the best comparison group, but we'll still be able to see that there was a significant gain. Okay, we just will have to hedge a little bit on the range of the gain, the value of the gain, as we translate that into alternative measures. So this is what we mean if you go to slide 23. We have this index, EQ index, and the program to do it. This is why it has to be measured as is. I just take the responses and I put them into a computer program called STATA, which is a statistical analysis, and it gives me the index. I don't even have to do any programming for it. I mean, I could do it because it's an algorithm, but the algorithms already existed in a very easily used program. So before the intervention, somebody had an EQ index of 0.59. After the intervention, the EQ index is 0.76. We look at the standard errors and we find that those are significantly different from each other in a statistical sense. With a high level of probability, we would reject the null hypothesis that those are the same number. And so we would conclude that the intervention had a positive effect on people's views of their lives, and that we saw a significant increase in the quality-adjusted life years that a person enjoyed after the intervention. So we get to slide 24, which is my last slide. That kind of leads us to where we are. The purpose is to inform policymakers, establish if the interventions compare favorably to outcome gains across the cost of intervention, and against other possible interventions, both for the same problem and for other problems. Benefit cost analysis does that all in terms of dollars. Cost effectiveness analysis can be done in dollars, but also can maintain benefits in clinical or other forms like QALY. And the QALY is the one that is generally used by now the NIH CDC to inform policy at the national level. So we have to, well, we don't have to, I think it is in our best interest to do the QALY analysis, understand the limitations of it we have, and use the gains in the other clinical and dollar forms to draw our conclusions of the benefit of our program. That's what I have. Anybody there?
Yes. So,
oh, good. I was starting to think I had done the whole thing by myself.
No, you're here. I'm here. So this is Denise from South Central Foundation. So I was just, so the EQ5D, it has basically 6 items, the 5 domains plus the 1 overall, or are there more items than that?
I'm sorry, I lost track of what you were asking me.
Oh, I was just trying to figure out the EQ5D, how many total items it.
Oh, okay. Whoa. I think there are only like 6 or 7. I mean, it's very short. I can't tell you off the top of my head, but they basically ask one question in each domain, and then the overall question, and probably and then and then some demographic questions about age and location, things like that.
Okay. Right.
I'll call upon somebody who's not me to make sure that everybody who's participating can see an EQ5D.
Yes.
Okay. Clem will make sure that everybody gets an EQ5D.
Okay, and then the other measures too, the DAT cap, the modified one, is that still being worked on?
That hasn't even been started working on yet because I'm trying to catch up.
Sure, absolutely. Okay.
Okay, see, I see Amber just sent out the EQ5D, I guess just to me, so I can open it up and let's see if I can give you a quick response to that question. Except my computer, here, now I'm getting into a place where I can look at it. So, 1, 2, 3, 4, the 5 standard questions, the overall health. That's it. And then, of course, we're going to have we'll be linking that to, so it's just 6 questions.
Okay, great. Thank you.
Hi, Robbie. This is Kaimi again. Are you going to be talking about the non-study resources survey?
So Clemma asked me about that, and if we're going to talk about it, she was supposed to prepare for that. I mean, I was going to weigh in, but I kind of ran out of time.
Okay.
But I can answer some specific questions about that if you want.
Well, and that was really the one that I had some concerns about a few of the questions.
Well, give me 1 minute, okay? I want to pull it up.
Sure.
Yeah, and sorry, I have to apologize. I was going to try to get to that last week, and then some things came up, and I wasn't able to. But I know, I'm such a slacker.
So the last copy I have, I think, is the 18th of February. So let me pull up that copy.
Okay, I have the 4th.
Okay, so what type of questions were you worried about?
Well, I really liked how you have provided the yes/no for lots of different hospitalization and outpatient appointments. I like that a lot. I guess number 4, question number 4, 9B, and 11. Okay, hold on. I'm on.
Okay, boy, this is going to be hard to do because the version I have goes from question 3 to question 5.
Okay, so I'll read question number 4. Since your last visit, have you had any of the outside services or programs mentioned above? Have you seen a therapist, psychiatrist, psychologist, counselor, or social worker?
Yeah, that's question 6 on the copy I have, but I got it.
Okay. And then how many times did you see a psychiatrist or psychologist? I'm just wondering, what other people think about that question. Particularly the psychiatrist or psychologist question. I know Denise is on, and I don't know if Valerie's on or not.
Joy's
Okay, Joy. Do you think people will be hesitant to answer that question? Honestly?
This is Denise. So I think first of all, I think the study we're doing is in a clinical setting, and so I think the context is probably a little different. I think what I would need for tribal leadership and for other leadership is to understand, just have a written description of, that question and kind of why it's in there. What it doesn't include, which is, some of the things in our system is we have a bunch of peer groups and other types of groups that aren't run by, quote, professionals, but more paraprofessionals or even lay people. So, I see the, need to ask about kind of behavioral health, but.
Okay, could I weigh in here? This is Robbie again. So that's really important. If you know, I think we and Clement, can you make a note of this? If there's a lot of peer interventions of this sort, then we need to have that in the question as well, and we should have a specific question about whether they've seen peer support as well. Almost, because I think it would probably be the biggest problem, could see getting rid of the reasons for seeking treatment. That's still in my version. I don't know if it's still in the version that you're looking at. The reason we want to ask these things is what I was talking about, trying to make sure that we control for other things going on in somebody's life and health care that would exacerbate or mitigate the cost of the intervention. You know, so for example, we're going to be doing this program, these questions before and after the intervention. And let's look at one of the ones that's designed to control hypertension. If we see that there is, you know, that most of the people who are seeing getting some sort of counseling before had high hypertension, and then afterwards, as their hypertension went down, they also saw had less need for counseling for whatever reason. This is an unexpected side benefit of the program that we can't attribute directly to it, but if it's pervasive through the responses, it would almost inform, hey, maybe we need to look at this. You know, maybe just living with hypertension was having a really bad psychological effect on people, and lowering the hypertension, besides the health effects, the direct health effects of hypertension, might actually have some mental health benefits as well.
Mm. So I think to respond probably to what Amy may be asking is, I do think within our setting we've done a lot of work to reduce the stigma of seeking behavioral health services, but I think that stigma is still there. And so I don't know if that's part of what you're concerned about, Amy, in your particular setting.
Yeah, and I think a lot of people may seek, like you mentioned, more informal mental health sort of services, you know, because a lot of people don't trust the behavioral health people and don't want to be seen going to behavioral health services. And so how do you, like you said, Robbie, we're going to have to include something in there to get, you know, information about other kinds of mental health support that people might seek. But, and I guess in some of the survey questions we ask a lot about support from family and friends. But how would you capture that? I mean, we'd have to ask questions about family and friends that they might talk to about things that bother them, rather than going to a psychiatrist or.
So can I? Clem and I can work on this, but I'd say we should take question 6, add in some, you know, start with, have you worked with anybody for informal, with families and friends, or seen a therapist, include psychologists, but then instead of how a psychiatrist or psychologist or counselor or social worker, ask, do you primarily use a formal therapist or an informal therapist?
Mm-hmm. Great.
I think something like that would be quite appropriate with this population, from what I'm hearing now, and quite informative.
Yeah, and there are traditional healers too that people use.
Right.
So.
We
Okay.
can even say we can see I would. Well, I don't know. Would you put traditional healers in a formal or an informal setting? I mean, would you say that's formal or informal intervention?
What do you think, Denise?
Well, in our setting, it's formal.
Yeah.
Okay. Well,
we're going to have setting variability in terms of what's available and what's kind of, but there's also informal too.
Okay, so we need to, Clemma, this is something we still need to work on, obviously. and we're going to need broader feedback on
Yeah,
this question.
so I just resent the latest versions I have to. Okay, well, I just sent the latest version. There's been a lot of versions flying around. So the first thing we're going to do is Courtney and Amber and Robbie and I will just make sure we have the latest version. And then I just sent out what I thought was the latest version to the 3 project leads and Robbie and me and Amber.
Yeah, I'm looking at it now.
Yeah, so we'll make sure that that's it. And if it's not, we'll try to send you the most recent version later today. But then what I would suggest is that each of the 3 project leads or whoever else they think is most appropriate to do this, go through it and make any notes that you want Robbie to know and send those to him, CC me and Amber and Courtney, and then we can incorporate those into the instrument. And again, since this got so far behind with Sean leaving and then it took us a while to figure out, who's going to replace him and get Robbie up to speed, I know that this is substantially behind the curve compared to the other measures. And so, we realized that some of the, especially in ACTS that's going into the field soonest, at baseline in the beginning, some of the participants just might not get these measures yet. And that's just something we'll account for in the analysis. I think it's reasonable to assume that that'll be kind of a random missingness with respect to the outcomes. So I don't think it should be a problem, but just that we understand that you may need to go forward with your IRB submissions before all this is wrapped up, because we want to make sure we do it right. And it's possible that this might even be a paper in and of itself, the process of kind of tailoring this to be appropriate for these particular populations.
And then I'm assuming, Clemma, that we'll have a call kind of as needed to have a discussion about any modifications to the measures or additions.
That would be, I think that would be my preference. Robbie, does that?
Sure, yeah.
Yeah, so if you can send them to him first, then we can go through them and try to make a new proposal, with the proposed revisions based on your feedback. And then we can discuss those and hopefully kind of efficiently finish it up. We wanted to try to do our best to get something to you. That was our first attempt at that based on the feedback from the annual meeting, but with the realization that you're going to need, that there was going to be more of a process involved.
Okay, great.
Well, this is Amy again. I want to thank you, Clemma and Robbie, for putting this together and hearing us and being flexible.
Oh, sure. No, it's actually been kind of a fun process for me to understand more and more about how these things affect individuals.
Sounds great.
Survey.
So is there anything else that I can respond to people about, or?
Not at this point. I'll look at them. I'll look at the email and send some comments once I have a chance to look at it.
Okay, and yeah, I'll either send you an email confirmation that what you have is most recent, or we'll send you an updated version. Okay. Again, I'll try to do that today.
Okay, great.
So are we done?
Thank you.
Thank you, Robbie, and thank you, everybody. I was late to the meeting because I had an issue with my son at school that I had to go deal with, but so I apologize for that. But this was very interesting and very informative.
Well, thank you all. Looking forward to working with everybody.
Thank you, everybody.
Thank you.
Thank you.
Bye, everyone.
Bye-bye.
Bye.
Thank you.
All right.
Yeah. And do you want to talk about
Success. Sort of, yeah.
Okay.